We'll be setting up the recording with our follow-up emails. As well today, please ask any questions in chat. You'll receive, again, slides in the recording on our follow-up emails during today's Q&A and reporting out from our breakout sessions later on. Feel free to either comment in chat, as folks are now, which is great to see, or use the raise hand feature, and we'll call on you. So welcome everyone to the second in our webinar series on addressing the housing needs of people with behavioral health needs, leaving or diverted from incarceration. Today, we're discussing defining, screening, and assessing for homelessness risk. And yeah, on to the next slide. We're brought here together today under the support of the California Healthcare Foundation, who's dedicated to advancing meaningful, measurable improvements. The way the healthcare delivery provides care to the people of California, especially those with low incomes and people who are not well served by the status quo. And we are the Council of State Government's Justice Center, a national nonprofit, nonpartisan organization serving all three branches of state governments and counties, really, to increase public safety and strengthen communities. And on the next slide, our agenda today, we'll hear first from Brendan Grealish, as Executive Officer at CCJBH. We'll talk about our report as it relates to assessments and get into screening and assessment. You'll hear from fine folks in Sonoma on their process and what they've got going on about their program. And we'll be moving into our breakout groups before leaving you with some resources today. And I'll turn it on over to Brenda.
Thank you so much, Thomas. So my name is Brenda Grealish, and I'm the Executive Officer for the Council on Criminal Justice and Behavioral Health. We focus on individuals with behavioral health needs who have become involved with the justice system. For those of you who might not be as familiar with our work, we're a 12-member council. And we've been involved in working in the housing space for a couple of years now, and we're really happy to partner with CSG's Justice Center to produce the report that has led into this webinar series. And so given all the investments that our state is making in the area of housing, being able to take some time and make sure that our justice-involved population is able to benefit from those investments, particularly those with behavioral health needs, is absolutely critical. So just want to thank the CSG Justice Center for all their hard work with us in trying to bring this to a reality. The report was supported by the Melville Charitable Trust, and this webinar series is supported by the California Healthcare Foundation. And so making those possible, really want to say some big thank yous to them as well. And then also thank all of you for taking time out of your busy schedules today to spend some time with us to learn about the assessment, screening and assessment processes, and also having Sonoma County here with us today to talk about the wonderful work they're doing in this space. But I know all of you work very hard, and I want to thank you all for the work that you are doing to bring this to life, and for spending your time with us here today. So with that, I'll turn it back over to Thomas to get us into the trenches. Thank you.
Thanks so much, Brenda. Really, all of this would not be possible without Brenda's continual work and advocacy and bringing everyone together and really having a wonderful vision for this. So on to the next slide. So this again is the second in our series. Please note that if you've registered for our fourth session already, you've probably got our updated email that will still be taking place still on Thursday, still at the same time, but on March 24th. Look forward to seeing you then as well. So on to the next slide. With our report that Brenda mentioned, we identified a number of areas that we can really move this work forward in. And one of those that, in talking with folks across the state is, of course, assessing or using data. So on to the next slide. When we talk about recommendations around assess, we're really really getting at like identifying people experiencing or at risk of homelessness, assessing their needs, while also compiling these assessments to quantify what's needed, having that feedback process for all of us. On to the next slide. And, for what actions we can be taken at the local level on assessing, this ranges from adopting assessments for folks who aren't assessing already, helping facilitate those partnerships to really make assessments meaningful across a range of areas, and so that things aren't just being asked and then doesn't go anywhere from there. And participating in matching efforts, which can be a whole range of things. And there's also some questions that folks can ask, especially if they're working in a jail setting or in probation, etc. Like, for example, like, is our jail part of a health information exchange? Like, do our contracts require in-jail providers to participate in sharing? Things that, are helping facilitate these partnerships, making sure that people aren't asking questions over and over and over again, and really using data altogether. So in the context of how many people we're talking about, my colleague Charlie had gone over this during our first session. We have this overlap of homelessness and mental health in incarcerated settings. This is really also just really giving a really general sense of what you might see when examining your own assessment data and what you might expect to see. And on the next slide, we're really looking at this intersectional data on housing and service need. And of course, there's lots more intersections to add. This is at its base, looking at folks who both need some high level of ongoing rental assistance, plus perhaps intensive mental health services, as well as folks who maybe need less intensive mental health services. And we know that these numbers can range up to 10% for folks on the super high acuity end, and a bit lower, between 8 and 16% for folks maybe on the lower end. So this also, we see this play out when we're looking at data in IST space, and really seeing that homelessness is often coming up. So we know that it is being tracked in some spaces in incarcerated settings, and that lack of housing, the lack of affordable housing is playing a large role already. So screening and assessing around homelessness. On the next slide, really overall principles are similar, really, to existing processes for mental illness and for substance use disorders. For anyone involved in stepping up, the national initiative to reduce the number of people with mental illness in jails, this will seem very familiar. So having accurate ideas about prevalence, having common metrics to track ourselves against, making sure that we're, again, connecting with folks out in the community, and really having data to inform what scale of housing supportive services you need in your community. And really ultimately determining who's experiencing homelessness so you can get them connected with the right services. And on the next slide, now we do have foundational principles. I think anyone who's asked questions about homelessness, about behavioral health, knows that part of this always is building rapport. And that's also where, where it's appropriate to build rapport. This is not easy in settings where things can get traumatic. Talking, being explicit with people about why people are being assessed, especially for homelessness, making sure that ultimately what we're doing is trauma informed. And for folks in the housing side, HUD is also really focused on this, and they've put out some great resources on being trauma informed. And having an idea of why people might be concerned about answering, such as being held in jail longer. That's a real concern that some folks have. Um, and really, this is where community partners come in. And it's particularly exciting with the benefits that are going to be coming down through CalAIM, with InReach and having folks who are specifically leaving justice settings eligible for benefits coming up in January of next year. And really, we'll hope to preview this during our final webinar. And also knowing that that we really want to have a shared language with our partners. It's so hard with so many acronyms that each of us have in each of our systems. That can take so long to learn if you're in it even every day. But so that we're talking about common ideas about homelessness or at risk of housing, while still knowing that there are challenges around federal definitions of homelessness, especially when it comes to jails and prisons and length of stays, and really then being able to problem solve around like what state resources are available that don't have those same kind of not guardrails, but those same kind of qualifications to them. So on the next slide, that's also here where we're talking about assessments and trying to incorporate them into different settings like incarceration, like into probation, into reentry processes generally. And at its core, really, it's about being simple and about having things be at a place where it's possible to navigate someone to really support their successful placement. And while we're trying to make questions simple in these processes, making sure that they're asked of everyone, so we're not missing people, so people aren't falling through the cracks, which we know can just be so easy to happen as people move from one system to another. That with how much time can be asked of staff, particularly this is the pandemic, we know that things can just be harder with how much time we have available, that really things integrate into what we've already got going on, like booking processes or medical screenings, that these are things that are already happening, and it's places that we can fit these questions in, and really make sure that we're not both burdening people with how many questions we're asking, but also that we're not burdening staff with things that like take 3 hours and another different questionnaire session rather than asking like 1 or 2 questions at booking. And again, always we'll go with connecting to community partners for successful navigation and to really flesh out the questions that are being asked and ask more in-depth questions that are appropriate. That's on to the next slide. Now we're really looking at the needs of the whole person at the intersection of complex care needs and housing and criminal justice. And this is all ultimately making sure that we're responsive to their needs, to their risks and strengths, and using all of this information together. And I mean, here, like checking the boxes, but really making sure that we're using like criminogenic risk for folks who might be under supervision when they leave, as well as their housing and supportive services needs, and making sure that they are getting services that are right sized for them. So we're not trying to fit them into programs where they might not find success and where programs might not be successful too if they're mismatched. And also that we are sharing this information among partners, so that we're not just asking these questions and then that stops and that's it. So on to the next slide. As a team, even though there's 3 areas the team should be asking about generally, and some folks, some communities, you might not have everyone at the table. You might not have your continuum of care, might not have a behavioral health partner necessarily at the table while you're working towards these questions. If you're coming at this from the strictly community side, you might not have a CJ partner. This is making sure that all of these question areas are asked by members of the team and fitting that information together. So on homelessness, it's choosing the right questions for your context. Not everyone can or should be doing in-depth questionnaires. And sometimes one or two questions be enough. We see this in Ohio, we see this in Nevada, we see it across the country that sometimes just asking 1, 2, or 3 simple questions can be enough to figure out that, yes, I need to have our community partners do inReach or do teleconferencing or just have other connections to really flesh out what homelessness risk means for someone. But it can depend on your setting. And this is one of our resources that we'll leave you with today. So on the next slide, it's also about individual experiences and making sure that folks are getting connected to the specialized services and providers that are really responsive to them. And especially those that are potentially tailored to their experiences, like HUD-VASH for veterans, like HOPWA for people who have HIV, really making sure that they're going to be getting these services, or at least you'll be trying to get those referrals for them and trying to do that problem solving for them to get them those services. And on the next slide, on our third section, around really essential wraparound services. So those employment supports and other things that can really come in handy and help bring down barriers for folks once they're in the community. And making sure that benefits are back and active, so that folks are connected with Medi-Cal, that their food benefits are back and active. All those things that probably everyone here knows that sometimes can just take so long sometimes for not great reasons. But if we intervene early enough, hopefully very much reducing those times when people don't have benefits, or making sure that benefits are connected before people leave, ideally. And on the next slide, and as we're talking about having all of these questions together, we know that assessment's really a process. It doesn't just happen once. It happens within a moving system, different people coming and going. But really that we're using questions that lead to specific outcomes. And then we have questions that are really helping to move people along to the resources that we have available in our community. And that we're also tracking assessment data, so that those questions aren't just being asked, people aren't just being referred, but we're also bringing that data back to inform what we're doing. And we'll come back to that in just a minute. This specific process that's up here on the screen, this is a prison assessment process, so a lengthy process that draws out over a month or so, maybe more. Definitely more lengthy and more time than probably anyone has time for in a jail setting or in community supervision. But these steps are still, although much happening at a much quicker pace, it's still the same steps of like, people come in, we have to ask questions, and then we need to figure out what to do next. So it's making sure that we're really keeping track of what our processes are as we're asking people these questions. And on the next slide, assessment doesn't stop at the door. I think we all know that. If I was out in the community doing an assessment, in a psychiatric inpatient unit, even if people were going back to my own outpatient clinic, it doesn't stop with me. I have to do so many other referrals, get people connected to other resources, other housing. So this is really, I think, at the heart of the problem solving that Sonoma will get to in a minute. And again, that we are tracking both the assessment data and, where possible and where we can, using outcome data on top of this for our monitoring and evaluation. We're not able to address racial equity if we're not tracking outcomes, if we're not tracking assessments. which we'll again come back to in a second. But ultimately, without data, we're not going to be able to address race equity, that especially being at the intersections of all of our systems in housing and criminal justice, where we know this just exists systemically. And we're not going to make a dent in that without using our data and evaluating our processes. The next slide. We know that data should be active, using it for feedback and really seeing those outcomes. It's necessary to make cases for investing in housing services. Like if you're going to your county, they need to see how many people are we talking about? How many units do we want to invest in locally if we can? Especially there being an affordable housing crisis across the country, in California specifically as well. It's hard to make the case that, oh yes, we need to generally prioritize these people or create more units for this population without those kind of numbers. And, again, it's working with our partners on what matters to each partner. Criminal justice agency might say, it's great that we got people connected. That's what we care about. And then housing agencies will be like, well, we also care about, are we getting connected to people who are permanent options? Are we getting referrals like at the time of day that we can handle and not necessarily like after hours? Ways like that to work together. Also sharing data where possible, and celebrating successes. This is hard. This work is hard. We don't always tend to celebrate successes. Pandemic's hard. To avoid hopelessness, sometimes it's just something that we must do, is celebrate those successes, celebrate when someone gets housing, celebrate when someone doesn't fall through the cracks. And on to the next slide. It's kind of easy for me to say, yes, we should track racial equity. But actually incorporating that is something that we must do. And this is just a couple of ways that we can try and diagnose racial disparities within our systems. We can be looking at sentencing, seeing if there are any differences in how people are getting sentenced, and could even see, is it affecting eligibility for housing? If someone is, is incarcerated 90 days or longer over the course of a year, that can knock someone out of eligibility. And really, is that top of mind during sentencing? It's a question to ask as well. Also this looking at disparities requires work also to track where questions are leading, and maybe are some people being referred more often than others. It's so important to see like what are the answers to our questions and how are they actually playing out and where people are going. Also looking at, especially for leaving jail settings, leaving incarceration generally, looking at like what are the terms of release? Are they being also applied evenly? And also making sure again that like releases aren't happening in the middle of the night, and making sure that things generally are working between partners as well. And looking at acceptance rates, this is something that can be harder, but some providers might be accepting everyone, which is fantastic. You have some really great providers in the community, and you might see other providers that just aren't accepting anyone. And it's important to raise with our partners about what's going on maybe with criminal records, or if we see any racial disparities in those acceptance rates. HUD is very interested in this work, and especially around protections with the Fair Housing Act and how criminal record denials can violate the Fair Housing Act, given rates of incarceration. And it's something that housing partners, this is probably like in their mind. Maybe it's not top of mind, but maybe sometimes needs to be raised in the conversations around the Fair Housing Act for them. And on the next slide, we said again and again, like, oh, let's track assessment data. So easy to do. Of course, anyone who's tried to track assessment data here can say, no, it's not easy. It's hard. True. Very true. So just sometimes if we can track even just our monthly assessment data, you can use data then to help ourselves and help our teams track this, celebrate successes, see what pain points we have. We have one really simple tracking tool that if anyone wants to reach out to me today and ask for, happy to share, simple Excel file. But really using this data to track what's going on and really support our work together and make sure that we can give each other feedback. And we can do this in ways that are not sharing personally identified information. It's just even from aggregate data and see what's going on just even at the system level. So we're not tripping up in some of those big questions around like HIPAA or some of the HUD protections. So just even the sharing of aggregate data with partners can really help to facilitate those questions. And before I go on to the next slide, I've just gotten some questions about the presentation being shared, and both the recording and the slide presentation will be shared in our follow-up emails to this webinar. So if you've registered today, you'll get both. And now we'll go on to the next slide, and I'll turn it over to Beth and Asen. Very excited to have you each with us here today, and thank you so much for having time to share your experience in Sonoma County.
Awesome, thanks. Hi, everybody. I'm Beth Hennigan. I'm the Executive Director at Interfaith Shelter Network.
Hi, everyone. I'm Asen Zamora. I'm the Behavioral Health Clinician for the Jmhcp Program, and that stands for Justice and Mental Health Collaboration Program here in Sonoma County.
So I think we wanted to kick off with like a little bit of our county context, what our provider community looks like. And it looks like we've got a little bit of data from our Jmhcp program from the beginning of 2020 through the calendar year of 21. So 68% of the folks that participants in that program, which is likely an undercount just because not everyone's reporting, in an upfront manner all the time about it, but are homeless, transient, or living in a shelter. So prior to Jmhcp, our organization, IFSN, Interfaith Shelter Network, has been partnered with the probation department and behavioral health for close to a decade now to provide housing supports for folks that are justice involved and oftentimes struggling with behavioral health issues, sometimes significant, sometimes less acute. So, just to kind of, as we talk through this, I think it's important to set a context about what those partnerships look like and what the roles have been, because I think a lot of the reasons that our assessments processes for this demographic are what they are is because of a lot of mutual trust and kind of embedded collaboration and communication. So it started, like I said, close to a decade ago with one house for folks on AB 109 supervision. We now have 7 houses for individuals in a variety of different places in the justice system, including pretrial, release, and all the way to, prison discharges. So I think that's like an important piece of it. Behavioral health has been involved with us the whole time. So they've been our referring partners embedded in either the probation department or like Asen at the jail. So assessments start on that side of things. So I'll let Asen kind of take it away.
All right, thank you, Beth. So yeah, the Jmhcp program really is for bringing more justice and equity for people who don't have enough money to bail out because of our bail system. So there are every person who comes into booking gets a pre-arraignment and pretrial assessment to see if they qualify for either pre-arraignment release or pretrial release. And out of those people, if they are not released on pre-arraignment or pretrial, on regular pretrial, then they'll have an opportunity through my program to get released on mental health pretrial. And how I screen for that is every person who comes into booking gets a mental health screening from the mental health who's currently in the jail. One of their staff does a screening and creates an internal behavioral code, or an IBC code. And so every day I see who's been in booking and who has an IBC code, meaning who's getting mental health treatment in the jail. And out of those people, I review their mental health notes and their management notes, because I have access to the county behavioral health system, also the CrimNet system, so I can read management notes from deputies on and where people are housed. So if someone's in a safety cell because they're a danger to themselves or others, then that would indicate to me that most likely they're having a mental health crisis. So that's the initial screen. Once I identify somebody who does have a mental health need, I send that screen to the court to let them know, hey, this is a person who may qualify for mental health pretrial release. You might want to refer them to me. Most of the time when I send those, the court does send me back a referral, and I have 2 to 3 days in order to do a more thorough assessment and to screen for substance use treatment, to screen for homelessness and housing referrals, and also to assess for level of mental health care that that person would need. So a lot of times the discharge plan and the housing referral really does depend on the person's mental health status. So if the person's in a safety cell and they're a danger to themselves, then my referral for them would be to, I would put them on a 5150 hold and send them to our crisis stabilization unit. But if they're more stable and are able to, be around other people and get along with other people, maybe share a room, then and I ask them, where will you be staying when you get out of here? When Thomas was talking about the ways that we assess for homelessness, and that can be quite simple. In this case, it really is. It's just basically like, hey, do you want to get out on mental health pretrial release? And if so, are you okay with being on pretrial supervision, because you'll be supervised by somebody, that you'll be supervised by probation. Some people aren't okay with that, so they just decline. But other people who do want to get out on mental health pretrial, I ask them, okay, well, if you do get out on mental health pretrial, where will you be staying during that time? So I try to keep it simple like that, to not be assuming. I don't like to say like, are you homeless? Like, I don't say that, but where will you be staying? And if they're like, well, I don't have a place to stay, then a lot of times I do refer them over to IFSN. And we have a house for Jmhcp specifically, so that's really cool. There's eight beds there. So that's been very helpful. Sorry if I'm rambling. I'm just like going really fast.
Yeah, no, it's awesome. So I guess once the referrals trigger, I mean, I think you're doing like the scope assessments as well. Once the referral is triggered with us, there's consultation. ASIN's part of our team for sure. Like, we're all kind of part of the same team, so we're talking all the time. So usually we'll hear about cases that are coming to us before the referral. Sometimes it happens really fast, and I think we've done a good job between all of us of like figuring out how to be flexible or embed enough flexibility to catch those last minute discharges or last minute referrals as well. But really, as the provider on the other end of this, we're initially only doing a scope assessment. So Are they doing IADLs and ADLs consistently? Are they appropriate for our level of care? And that's enough for an intake on our side. So we're really taking most folks referred. And then, post enrollment, usually the first couple sessions are sort of around treatment planning and assessment. So what that looks like is a fairly standard biopsychosocial style assessment, some of which, if ASIN's already covered, we'll collaborate and not have to re-ask some of those questions about trauma history and that stuff. There are differences, of course, about how someone's going to respond in custody versus out of custody. So it doesn't always work 100% of the time. Or maybe someone's not comfortable answering something in custody that they might be more willing to disclose out of custody after some rapport is built. And so, like Thomas said, assessments happening throughout the life of a case as it's an ongoing thing. So that assessment, that level of assessment, I think it's important for us in this project and projects like it specifically, to not use an assessment as a tool to screen out, right? The reason that the initial screening is primarily based on scope of practice, scope of competence, all that stuff, is it's really to screen folks in more than out. And then getting that more detailed case planning stuff is part of the plan with them to do in a collaborative way. And
Yeah,
so, yeah.
Right now, the main the main rule out for this program for court is really just having a violent felony charge. And if the person does not have a violent felony, then really it's just based on whether or not they agree to being on supervision. And if they have a mental health need, that's what.
Yeah, and that's not a piece that was implemented on our end. Like we also serve folks with violent history. So I forget at what point in the funding like hierarchy that kind of came through. It might have been advocacy from a different point in the system. So I think that to kind of jump around a little bit, like stigma isn't a really important piece. And I think that part of the reason why we're comfortable with a simple scope assessment, regardless of previous convictions, history of arson, history of violence, all of that kind of stuff, is really because of the relationship that we've built. So we are confident in the safety networks around us that we can contact if there is an intervention that's needed, because our protective factors definitely rapport building with folks, and that tends to be successful most of the time because I think that there is stigma sometimes in the community-based organizations, definitely like just in the places that we live in general for this population. And so how to meet them there in a way of informed radical acceptance sort of an approach to get folks connected to the services that they really need to try to prevent or interrupt the cycle that they find themselves in is, in my humble opinion, starts at assessment. And really how do we do that together as a continuum of services and care, and while supporting the end of the justice system that needs to be supported in terms of showing back up to court and getting through all of those hoops, because it's a lot. I mean, for folks that are court involved and homeless, there's so many different places that they might have to go and get another of the same assessments. And so trying to be really collaborative in that way to address and, I think address, but also dampen the effects of stigma that these folks have to face.
And to kind of help with that, all the barriers of accessing, resources after reentry. I try to, send the verification of incarceration to Social Security myself to reinstate benefits right away upon release, or I'll call I'll fax in the prescription for the person so that they can have their medication delivered to wherever they're going to be going. So things like that, because those things have been really a problem and a barrier in the past, which was, reinstating benefits and also um, continuing on the medication that the person was on while in custody.
Yeah, and I think it's, again, to highlight that communication piece. If ASIN like starts the process and they're getting out and there needs to be someone to help finish the process, like that's also communicated upon referral. So I think, like ASIN, you said it, like the simple, practical, kind of concrete, solution focused assessments for the immediate discharge plan is an integral piece of getting folks to even want to engage, but also safely engage, and with that sort of equity center around having them be a co-creator in their plan moving forward, I think is really an important part. And then did you want to talk about IMDT a little bit? Because there's also even more consultation that we do. Oh, I think I'm going to butcher the name while Asen's.
Thank you. So yeah, IMDT is an interdisciplinary, multidisciplinary team with different agencies in the community. So behavioral health is there, the different adult teams, our crisis stabilization unit, the homeless outreach teams, different shelters in the community, the public defender's office, probation. I can't think of any more off the top of my head, but we all go to this meeting once a week. And so every person that is in my program, I have them sign a release, asking them, are you okay with me collaborating with this team to get you more services? If so, then they sign it, and we're able to, that's how we're able to reinstate Medi-Cal so quickly, because Human Services is a part of the multidisciplinary team. So when I'm like, okay, I have this person, they're getting out in 2 days, they need their Medi-Cal turned on because they need their medication, delivered to the IFSN house. That's where they're going to be going. So it's been really, really helpful to be a part of that team and to give a heads up on, what the person will need once they get out. Sometimes what happens is, for instance, if a person had like a out of county warrant or something, then we're able to communicate that with the public defender's office. And sometimes they'll help us clear the warrant. Like when we know that someone, in the program, when they got out, they got hospitalized, and their probation officer didn't know that or something like that. So we'll be able to communicate that in the IMDT, and then there'll be notes in the probation, so then they won't put a warrant for their arrest or something like that. So it's been a very helpful collaboration and really remove some barriers, because we didn't have that. About 6 years ago, I used to be the jail discharge planner here for Sonoma County main adult detention facility. And at that point, we hadn't gotten the IMDT team together. And wow, it's a big difference now than it was before, for sure.
Yeah, the other thing I think that is really helpful, so we have that larger meeting, we're also part of the IMDT group, and then every other week, and I know this might sound like a lot of meetings, but when we think about the amount of barriers that these people see and how much we're able to get around those barriers with like one assessment and showing up to a meeting for an hour every couple of weeks, I think it's like the efficiency of the work done, in my experience with this project and this kind of cohort of service providers, is worth the time spent in more Zoom meetings, which I know we're all really excited about at this point in the pandemic. But we do have every other week, we have a Jmhcp huddle where we meet, and folks that are also involved with the cases are invited on kind of a drop-in. Everyone can come if they want to or need to communicate about something. So, mental health diversion has an invitation. Housing, Disability, and Advocacy Program staff has an invitation. So because they can be all, we said it was intersectional. I don't know if there's like a million different ways to repeat that, but it is such an intersectional space. And so sometimes there's many paths to a solution, but we want to make sure we're not duplicating, like I said, those assessment points or the work towards the treatment plan. So I think that's really helpful. That's been helpful too, because we get into more detailed case planning together and help each other figure out who should be doing what and all that kind of stuff. So updates on assessments, all that go there. So yeah.
I think I'm done on my part. I'm ready for questions if anyone has any, or if you want to have those at the end. Thomas, I don't know how you want to do that.
Yeah, I think we can open it up to questions if folks would either like to put the questions in the chat, or if you'd like to raise your hand through the reactions and raise hand button down at the bottom. We can unmute you and let you ask your question. I think while folks are getting their questions together, typing them out, I've got a couple myself. When we had chatted before about the program, you guys have definitely talked about some of the problem solving around like, oh, here's how we get someone's Medi-Cal reinstated, which is really just so great to hear about how that problem solving happens. Can you talk a little bit more about how the problem solving process goes with housing and maybe coming up with potential denials and things like that?
Yeah. So, I think those of us working in homeless services are very accustomed to, unfortunately, denials and appeals and all that stuff. And I'm sure the whole state is short on affordable housing and permanent supportive specifically. So usually, we start in terms of that with, like, if folks were usually the nexus in the service array where we're getting folks onto the coordinated entry list and various different low income housing. We have a really great working relationship with our local county housing authority. So we've gotten the opportunity to initiate a reentry pilot program for folks that are coming out of any form of custody, state or local. And we also have a fairly robust rapid rehousing program in-house funded through the Board of State and Community Corrections for reentry population at a state level. And so sometimes that's like, I guess first we're looking in-house to what long-term resources can for the permanent housing component further than the wonderful resource of the transitional house. How do we help these folks kind of get into a place? And so when it's something like a voucher, we know they're going to be denied. We start prepping the appeal as soon as and explaining to the participant, like, it's okay, we're going to appeal it. And we have a pretty good understanding at this point of like what HUD will ultimately accept or not accept. Very wonderful housing authority with, like, I think interpretations that are in line with a lot of the community-based organizations around HUD funded subsidies. And so we help them with all of the paperwork, and then we start prepping the appeal immediately for low-income housing as well as voucher subsidies. For our rapid rehousing style projects, we're just helping them figure out what's going to work for them and just encouraging tenacity and resiliency as we try to kind of get through all the no's before there's that yes, let's sign a lease moment. And, I think a big part of it is that when we were in development with this particular program, we very intentionally agreed and designed the project to not just be for when folks are on pretrial, but to be able to extend on a month-by-month basis when they were off, because why recreate the issue if they're in transitional housing? We don't want to cut it too quickly before there's a permanent housing solution. So sometimes it looks like they're getting into a longer term transitional program, sometimes permanent, sometimes we're helping folks get into a boarding care. Like we've worked collaboratively with ACEN to help people on conservatorship stuff and like kind of the whole gamut. So it really is a unique case by case thing, but I think using that assessment time to figure out and address barriers as early as possible, because it can be really discouraging for folks, even if it's like a normal part of the process for us.
Yeah, and that's I mean, that's just feels so very important, the assessment process, to be prepping people for everything that, yeah, that all of us would be like, oh yes, of course, like once there's a denial, we'll do this, take these steps. That's not always so clear to the people that we're talking to and working with. So I'm just so glad to hear that. Question from Kathy, looks like approximately how many people come through the mental health pretrial per week?
So it depends on, like, currently, because of COVID, we're a little bit slower, which is good. That not as many people are getting arrested as before, and when arrested, they're not being kept in custody as before. So yeah, so now it's been about like 12 to 15 referrals a week, something like that.
Okay, thanks, Jason. And yes, Brenda, also glad to have you here today. And the next question comes from Juan, and asks, do you think the success of your program partnership is in large part due to the size of your county and county population? And do you know if your program has been replicated in a large county?
That's a good question. Scaling is always like an interesting topic, right? I think that the success of the partnerships, it has been in large part due to like actors in all systems that are really dedicated and interested in making it work. Like I have both the division directors phones that we text each other when stuff comes up that we need to address. We do trainings with one another's staff. There's a lot more CBOs that are involved for like substance use disorder stuff, but it's been really an intentional and long-term process. And we've all just kind of made it, or tried to make it, a priority. I think in some ways it could have been easier because of the size. In other ways, it could have been smaller because of the size. Like folks were really, like initially, I think folks were like, why does the probation department want a relationship with a housing agency? Like on both sides of the fence. I think people were like, what's going on here? And now we're like so grateful for having such a long-term and integrous relationship. And we, value one another's feedback and development, and also going after funding or whatever, like we do those together often now. So I think I think a lot of the time it's about starting somewhere, like I said, we started with a very small house initially, and now we're really working towards like, how do we head this off before it's a redundant issue where folks are in and out of custody. So I think but that's almost 10 years in. So how to really initiate that conversation, I think is worth some time thinking about, regardless of size, which might be easy for me to say in Sonoma County, but I think it always starts with a discussion.
I don't know about like how many counties have Jmhcp in California, but I do know that in the past, when I was a discharge planner, I did visit other counties, other county jails, and it's not rare to have multidisciplinary teams in larger counties, which I think they have more than actually the smaller ones, right? So like for instance, we don't have a way to apply for Social Security in this jail for somebody who's currently incarcerated, but other counties do have a specific contract with Social Security, where I think it was like last time I went to like this discharge planners meeting, I was appalled. I was like, oh, what? There's other counties that can get somebody Social Security while they're incarcerated. And I think it was San Francisco County already, they start that process of getting somebody Social Security before they're released, whereas Sonoma County doesn't have that contract, and we're not able to start that process until somebody's after they get out.
Which right now is even like further out just because of COVID and
yeah, like maybe a year later, 2 years later.
Yeah, it seems like that sometimes for sure.
And Asen, a follow-up question to that, just to clarify for the group, is that the SOAR program that San Francisco might be using to help them get folks connected?
I'm not sure. When I went to that, it was like a discharge planner, like, gathering from different counties or whatever. I just remember being so surprised that there were counties who did have that contract with Social Security and were able to do it. And I knew that our county did not. And when I came back, I did ask around, like, how can we get one of those? And yeah, it was like, no, we're not going to do that.
My next question, I see some comments in the chat, which is really exciting to see some of that. Oh, I'm sorry. Looks like William had a clarifying question about the number of people who come in to pretrial and whether that is 12 to 15 people per month or per week.
So actually the 12 to 15 people are like actual referrals that I get from the court. But I mean, through like, is that as many people as I screen every day? No, like sometimes there's like 10 to 15 people a day that I screen. It just depends on the day. Usually like when I come in Monday, there are a lot more than on a Friday. But yeah, it's around 12 to 15 per week that I get like referrals from the court.
And again, we started this in December of 2019. So there's been time also to, I think there's been a lot of communication with the bench about what this program is, how to refer, like it's really like been inclusive. And I think that that's been an important piece of like getting the referrals to where they are today.
Yeah, and I have now like the more court, the more times that I go to court to advocate for someone's release, now all the public defenders know who I am. They'll email me and call me personally, be like, hey, what do you think about this person? And I'm like, okay, yeah, they sound like they have a mental health need. Send them my way. So yeah, I think that having the personal relationship with the public defender's office really does help the situation.
And that's such a both important and I think probably for folks on a call like this doesn't always involve the public defender's office, even though there's sometimes they are natural allies, and it's so great that you guys have that at the table and have built those relationships. It's really fantastic to hear. You guys have actually answered all the questions that I had separately as well. So I'll give people just another minute for questions. Then I think we will turn over to our breakout rooms. All right, I think we'll turn it over to our breakout rooms. And also, if anyone has questions that come up during our breakout rooms or after, feel free to ask away if Beth and Asen are able to join us for this.
Thank you so much.
Yeah, and Beth and Asen, thank you so very much for your presentations. I think I try to say this when I see folks doing such good work, but it's really heartening to hear about your work. And really also like how your processes have evolved during the pandemic as well. So thank you each.
Yeah, thanks for having us.
Yeah, so we will move to our breakout sessions. So we have about 15 minutes that we will randomly assign folks into our breakout groups. And while there, if you could assign someone, appoint someone, take one volunteer to take notes and report out. Now, when we come back, we'll call on groups to report out when we return. We'll also have a poll that'll just have 3 simple questions to answer. And then upon our return from the 15 minutes, and Charlie and I and Katie Herman will be bouncing around between the breakout sessions. You might see us. And yeah, our key question today is how and when do we assess for experiences of homelessness? And other discussion questions that you might find helpful as you're going along are what barriers do we encounter in this process? And how do we work together, or would like to work together with partner agencies in our community on case conferencing or problem solving? So I'll put those in chat, and then we will move to our breakout groups. Welcome back, folks. I think we'll give people a few minutes to come back from the breakout rooms. Welcome back, everyone. So we will start with some reporting out. We'll start with I believe room 4 might be our first one. If we can, and then also be throwing up a poll for people to answer in the meantime. So if someone from room 4 wants to share, raise your hand and we'll unmute you. And Charlie, we can see your screen right now. So fun for everyone to see what we're talking about while we're going on. I think, we'll just take out volunteers for the first people who want to share, and I'll put up our poll. It's actually Don, if you'd like to, or I'm sorry. If Rochelle, if you'd like to, okay, Don, great. I will unmute you. Thanks so much, Don.
Hello, I'm Dawn Patori, and I'm a program manager from Shasta County, California. And in our group, we had Rochelle from the Sacramento area, from River City Managed Care. And we had John from Butte County, case manager. So we'll start with the comments from Rochelle. Her group normally works with low income, chronically ill, and chronically homeless. The intake is done by navigators, and that's when they assess for homelessness experience. After enrollment, they make more assessments regarding their housing needs, and periodically they check back in to reassess their place in the process, where they've signed up for services. Some of the barriers we all share. Rochelle was nice to state them for us, is the lack of units. The demand is greater than the availability. Many of the people we come into contact with, they have a lack of computer knowledge or even access, and a lot of the housing services are online. A lot of our collaborative offices are closed due to COVID, so it's hard to refer our people to services when other offices aren't seeing them. In River City Managed Care, they are referring people to libraries for help with the computers. Recently, they've had some non-English speakers that they connect to their home language learning centers. Some other barriers that they've ran into is the chronic illness itself can cause delays, and then the needs of the families. Finances, the lack of deposits, lack of transportation or access to transportation, and then working phones, because all of our programs that we refer to or all of our housing lists, you have to be able to reach those people. And often, they have to change phone numbers, or they've lost their phones, or it's not working. So we all shared that we agree on the same barriers. In Butte County, John shared that as a case manager, he already knows a bit of their housing needs before he meets with them, because that's done in a clinician assessment. And then here in Shasta County, we have a community health advocate outreach team that has regular outreach 2 days a week with probation and parole. So that specifically speaks to the incarcerated population. We also have community mental health workers that once they receive from various sources homeless assistance referrals, we call up and contact them and do a homeless management information system assessment and entry form. And then all of the players in our community that receive funds for housing, we meet weekly to go through the HMIS coordinated entry by name list, which we staff and talk about matching those of highest needs with program openings and funding.
Yeah, thanks for sharing those, Don. So many of those things are unfortunately so universal. But also, Don, I've written down your name because the by name list is something we're always very interested in hearing more about. So might be reaching out to you for that. Yeah, gosh, especially about the need for more units. That's something that we certainly will go over in 2 webinars from now and helping to create more units, but it's such an acute thing. Also an important point about access to computers and computer literacy and how that, especially with how much we've all moved to online systems and how big of a barrier that can be. Someone else would like to volunteer to share in chat. We will mute you, and looking over the poll, it certainly looks like I think we will end the poll so folks can see the results. But yeah, it definitely looks like of folks who were looking at what's happening in our systems. Looks like a lot of folks are actually assessing right now for homelessness at the entrance to the systems, which is great to hear. We'll certainly love to hear more about that as well. If anyone would like to volunteer to share about how they're assessing or their assessment process briefly. And barriers, yeah, as Charlie mentioned, absolutely looks like having enough housing is the #1 barrier, along with some declining of what services we have available, as well as some time constraints or not having the questions in place yet. And for the third question, looks like kind of a general consensus that about 1/3 of folks are case conferencing, having leadership meetings, sharing data among partners, all of which are really exciting here. Would love to hear some more about that, or if anyone wants to put their email in chat if they are sharing data or have their integrated case management systems, things that we would just love to learn more about. And also maybe have help share in the future about those systems, because we know that's not always the case for people as they're able to work together in this space. Well, with no more volunteers and with us coming up to the half-hour mark, I think we'll move into our resource section real quick, just to let you know which resources will be included in our presentation today, and which resources we will send along with our presentation. Oh, Charlie, sorry, this is in presenter mode on that side. So first, we'll be sending along our second worksheet that those of you who registered for our first webinar have gotten. Again, this is always optional, but hopefully it's something that can help you have these conversations locally or help build out what you've got going on locally. And we'll be sending out the second worksheet for those who haven't gotten it already. We'll be sending out with our follow-up email in a couple days. And our next resource is the Assessing Housing Needs and Risks, a screening questionnaire that I went through earlier, which had the homelessness and supportive services and wraparound services. This is also available on our website. It'll be available from this link in slides. And on the next resource, we also have a checklist that the Justice Center put together on preparing people for reentry, and just kind of goes through some of these things, especially as the pandemic is worn on, just to make sure that we're checking all of our boxes, both in incarceration settings and out in the community, to make sure we're getting people all the right services in place, including housing, including Medi-Cal, all of those things. On the next slide, my colleagues, including Katie Herman, put together just a really wonderful workshop manual and did a really great workshop, not earlier this year because it's January now, early last year, on screening and assessment for behavioral health needs in California. And this manual is just so very helpful for having these conversations and working together on assessments, and really using this to work together as a team to flesh this out. And on the next slide, and this is our, again, our actually national standpoint about steps that the state could be taking, steps that states could be taking to increase housing access, and something that, while this is geared towards state leaders, it's also something that counties can bring to bear for themselves. For example, I think San Diego is using parts of this now to help build out what their partnership and work is looking like. It's just very applicable, even though it's geared at state leaders, also very applicable down to the county level. And also we wanted to lift up one of the recent reports that's come out on data sharing that Homebase has put out, and really focuses on different ways that data sharing and coordination can be happening between partners, also specific to California. And next, well, in about 1 month, we hope to see you again. So on February 24th, again at noon, we'll be moving into the connecting piece. So this all kind of moves from one thing to another, but we'll go into common practices for connecting to and using housing as a strategy for diversion and reentry. And thank you everyone so much for your time today. Really glad to have each of you here, and we'll look to see you next month. Thank you and take care.